Thank you so much, Helen, and thank you so much for the MPA for allowing me to engage and talk to you guys today. And I'm super privileged to be here, and I'm really grateful for you guys as well of spending your Monday morning with me to maybe get a bit of an awareness of the topic. Um, Now, the reason why, of course, we are seeing a massive shift, you see, right now. And I can see the way things are going with the integration of neighborhood teams, with the prospect of doing more in the community setting, the movement away from secondary care onto community services, all in the aid of helping achieve our patients' health and keeping them out of hospital. And really, today's session will be focusing on how we as community pharmacists and pharmacy teams can practically enhance our role in delivering the pharmacy first service, with the emphasis of things like otoscopy, but also utilizing the basis of what pharmacy first is as overcoming barriers to GP referrals, initiating conversations, and ensuring that we're looking and taking pharmacy first forward in terms of management of long-term conditions beyond that of designated pathfinder sites. And hopefully, I would like to give you some examples of what I've done in both my PCN role, but also as a community pharmacist as well, and the sort of trials and pilots I've done that has really highlighted the benefit for what we can do using community pharmacy as a base of community health and keeping our patients healthier at home in line with the NHS 10-year plan. So thanks again, Helen, for the wonderful introduction, and I'm most grateful. And as you guys know already, I've got a bit of a portfolio of sort of things going on in terms of working in primary care as a PCN pharmacist. I'm a superintendent for Lewisham Pharmacy in Southeast London, and have got hence engagement both in Southeast as well as Southwest London. But of course, education training is my real passion, looking at it from a GP pharmacist that I've created, but also working with as a tutor for CPP and also an associate director with Morph Training. And also my focus has really been on education around long-term conditions, as well as getting pharmacy first right so that we can help embed and flourish from that service. So what are we going to talk about today? Really, we're going to be giving you, hopefully by the end of the session, an update of what Pharmacy First will be moving on to, especially with the updates from the 1st of October and the slight tweaks and changes to our clinical pathways and PGDs going forward. I'll also be giving you some updates on what I've seen as community pharmacy first engagement lead, working as a project manager, and also engaging with GPs and PCNs and ICBs. We'll be looking at how we can utilize otoscopy as one of ways of improving our consultation, and also how can we position our pharmacy and ourselves as a long-term care partner with the NHS, with GPs, to ensure that as a pharmacy first model, we can use that as a foundation to actively lead on long-term condition interventions like respiratory, like hypertension, like cardiovascular disease, outside that of pathfinder sites. And what I did to engage with that sort of project and try to win those bids, so pitch with purpose, and some blueprint of what I've done that might help you going forward with your sort of engagement going forward. Yeah. So a little bit of background. I'm not going to teach grandma how to suck eggs, but as we know, Pharmacy First really an advanced service under the CPCF, and really enables us as pharmacists to provide advice and NHS-funded treatment where it's clinically appropriate for 7 common conditions. And we also know that these conditions are the consultation pathways, are clinical pathways that allow us to engage and interact with patients coming in with these sort of issues who have been referred to either by NHS 111, general practice, other healthcare professionals, but also those who are walking in because the patients are now aware of those services going forward. And really it exists as part of that incorporation of the CPCS and covers both minor illness considerations with the pharmacist able to supply urgent medications as well as a result of referrals and so on and so forth. So it really helps us embed this interaction with our patient going forward. Now, you'll be getting a certificate, so please, if you, I'll share this as well. If you got your phones, just scan this, okay, so that you'll be able to get certification, but also a little bit of feedback of what we can do better going forward. But I will reshare it near the end, okay? So let's get into it, okay? So what are the top updates that have happened this month, okay? Now, we know that following a clinical sort of stock take that's happened from NHS England sort of mindset, there have been minor changes made to the NHS First service clinical pathways, the PGDs and the protocols. And in anticipation of this sort of changes, we are finding that this is going to come into effect from Wednesday, this coming Wednesday, the 1st of October. And the updated service documents have already been published that you can find online. Now, the current clinical pathways are still until, they remain in place until uh, 1 minute to midnight on Tuesday, the 30th September. So please do have a look at the pathways, but effectively, the updates are really about clinical pathways in terms of certain conditions to improve the clarity and the alignment of the current best practices. We're looking at the PGDs, and there are slight adjustments that reflect, again, safety and prescribing standards before we prescribe, mainly around prescribing of antibiotics, and also the service protocol, which has got minor wording updates, which is allowing more from an operational point of view that allows us to make sure that we're doing the right thing correctly. So if we have a look at the general sort of changes that have occurred, the main thing is consider the risk of deterioration, red flags, and serious illnesses. And this really includes an explicit link to NHS resources and a link to NICE CKS as well. And it is included in the evidence-based support of decision making. So it's important from the NHS point of view, when we're providing services for Pharmacy First, that we are addressing the red flags very quickly, any risk of deterioration and any serious illness. And as a result of that, there's now greater emphasis on the gateway points and referral decision making. So there's more gateway points to ensure that if we've been able to exclude a patient because of high risk, that we still manage to get a gateway point as well as going down the pathway as well. Also, there's added reminders for red flags and urgent escalation. So, for example, being fully aware of news to score where appropriate and being able to divulge that information to our clinicians that we're speaking to, be it paramedics or A&E, so that we get the appropriate escalation going forward. And also, the pathways now consistently reference a return to pharmacy for reassessment and the timelines that are allowed for which. So it gives us a sort of like more comprehensive approach when we're doing our safety netting, but also if things get worse, what to do. If it's minor, come back to us. If it's quite major and that deterioration is occurring even after giving the treatment therapy for that patient, then they need to be referred onto the GP or appropriate healthcare setting for further review and escalation. But have a quick look at it now for individual clinical pathways. So from a UTI point of view, the age range is now clarified and it's explicitly used for women age 16 to 65 who do not have diabetes, which wasn't previously there. So if they've got diabetes, they're automatically excluded. Additional clarification is also that if they get urethritis, that might be caused by irritant or inflammation, not just post-intercourse. And also the wording has been adjusted for our PGDs where if you get pylophrenitis red flags, which includes things like flu-like symptoms as well. And again, referral to the NHS website for clarity and for further sort of reviews. So it gives you that sort of more safety netting point of view. And this safety netting has been expanded to provide more clearer signposting to things like sexual health clinics, as well as pregnancy testing if appropriate. Yeah. When we're looking at impetigo, the only addition is that the requirement for confirmed diagnosis in a consultation room. So if we're doing it, it's got to be done within the consultation room, so it's more explicit. There's also more emphasis on red flags and severe complications, again referring pharmacists to NHS resources, and reinforcement of advice on terms of good hygiene and adherence towards medication, because we know with our clinical documentation, if it's not written, it hasn't happened. So we need to be able to make sure that we've documented this to safety net ourselves as well as healthcare professionals, but also demonstrate to the GPs to whom this goes back to, that all appropriate sort of advice and guidance have been provided for these individuals. Okay, so there's also clear escalation steps in terms of the widespread infections for those individuals who have got immunocompromised status as well. For the benefit of those individuals with presenting to you with infected insect bites, the update has now added the mention of Lyme's disease, which is been quite significant, especially during spring, summertime. But also note that tick bites are obviously painless, and the inflammation and the sort of migraines rash that they might get may resemble other insects. So it kind of tells you that don't completely exclude Lyme disease because it's not explicit in front of you, because you'd have to do further sort of detailed differentials on those individuals. And again, the link that's then provided on the actual documentation and the pathway for this particular purpose then directs you to the guidance for what Lyme disease images may look like. There's also now explicit referral criteria for exotic or unusual insect bites, because obviously they would be required to be escalated quite promptly. Any sort of animal or human bites, and specifically looking at any sort of travel-related insect bites like malaria or tick-borne encephalitis. And as a result, again, for our documentation purposes, we need to have clearer safety netting advice, including the effects of the area for monitoring purposes, and to make sure that we're not excluding any sort of red flags. So we need to make sure if it gets worse, that it's been explicitly documented in our notes. For sore throats, the main changes are that have been added is head and neck cancers, red flags. So anyone who might present with persistent mouth ulcers or unexplained neck lumps. So that's been quite explicit in our guidance, but also stronger guidance for children has been fully established, where consideration must be thorough and the consultation must be quite thorough as well. And doing fever pain scoring, making sure that it's quite clear, and any sort of follow-ups that may be required for patients to return post-intervention, to make sure that that the treatment pathways and any sort of guidance that have been provided to the patient have been quite clear, and that is being managed. But if it's not being done properly or is not being identified, that those individuals are then reassessed accordingly. For sinusitis, acute sinusitis, the main emphasis again is on pain relief and self-care, because as we know, majority of these sinusitis indications are all viral, not bacterial. So pain relief and self-care as first line before the use of antibiotics. And this is really where as antimicrobial custodians and antimicrobial stewardship really comes into play. So if you haven't done your AMS training, do so. It would be really useful in this case as well. But also safety netting utilizing the NHS links. It's also important that we utilize the guidelines that we've got through target sheets, that we're consistent in our describing of viral versus bacterial sinusitis. And again, providing information to our public for clearer dosing requirements if they use nasal steroids. And also how to use a nasal steroid as well. Very important, because a lot of these individuals don't tend to use nose sprays very effectively. Shingles, the amendment made for shingles is that there's a slight confirmation on their classification from an anatomy point of view, that it's that previously the non-truncal involvement is now described as limbs and perineum. And it's also been added that if there's any sort of head and neck involvement as a red flag or urgent escalation. So it's much more clearer in its pathways. It's also identified that any red flags or serious complications can be referenced with utilizing the NHS link that will also be included, and also ensuring that individuals for immunosuppressed, including notification to GP when antivirals are supplied out of hours, or explicit mention to A&E and 999 escalation criteria. So in case those individuals may not be appropriate for acyclovir or any of the antivirals. And finally, we got acute otitis media, and the main changes for this is a more clearer definition between what is mild and severe cases, and it defines mild more as a self-care requirement where you might just need pain relief and it will subside after a duration of time, and a moderate to severe, which is consideration for either antibiotics or the ear drops. It's also given more clear guidance on the otoscopic examination and clarifying the referral steps around that, and added also the red flag criteria for systemic illness and any sort of pre-existing comorbidities that might exclude that person for further sort of escalation with pharmacy first or AOM. And again, NHS links, NICE CKS guidance has also been identified. And we're going to be going through acute otitis media in terms of presentations that we might see in our practices going forward. So I hope that gives you a bit of a bit of an overview of what the changes might look like, so that when you come across it on the 1st of October, I mean, please do read beforehand just to prepare yourselves and your teams in your pharmacies. But I think it's important just to be, it's safeguards us as pharmacists, but also ensures that we're giving the patient the best sort of direction in terms of where they need to be seen and how quickly they need to be seen and what else we need to be looking at. And it also simplifies the language a little bit more as well, making it a lot less wordy, a bit more articulated in terms of what we need to address. But you and I know we're having difficulty. We're not getting as many GP referrals previously, and there's been a massive sort of direction of change of why is this the case? Okay, so for those individuals online, you're more than welcome. If you don't mind, if you can please share with me, why do you think you're not getting these GP referrals? Why aren't you not getting an explicit referral from your local GP practice to your pharmacies or pharmacy? And if you can just jot it down, it'd be lovely to see why you think why you're not getting it. Okay. And I can tell you, I mean, I can give you an example from mine. Whilst you guys are thinking and maybe, jotting it down, why you're not getting the referrals. But for my case, potentially with my local pharmacy and with my pharmacy and the local surgery, potentially it could be as a result of being unaware of the actual process. Yes, they've been told, they've been, they've been highlighted, they've been engaged with, but ultimately people will only do what is either mandatory or brings them money. And effectively, it's not a requirement. And because it's not a sort of like mandated requirement, GPs and GP staff tend to go for the things which obviously are going to bring in the money. So I think that's been one of my sort of barriers to overcome with my local practices for my pharmacy. But I'll be interested to see what your barriers are, and please do share on the chat function. But here are some ideas that I've come across. Find that often referrals are not picked up timely by the pharmacy teams, which might result in surgeries not sending them through. So they've been disillusioned. They think, oh, it's not going to happen. It's just going to sit there in the inbox and no one's going to do anything about it. Some surgeries have got these sort of like rotational trainee GPs who coming in, coming out, coming in, coming out, as well as other trainees as well, like nursing as well. And as a result, have enough appointment capacity. So they feel like, why do we need to send them down to the pharmacy when we've got enough people to manage these minor ailments? Some surgeries who have got locums still don't provide the service. No, so some locums pharmacies still don't provide the service. Maybe they're not completely up to date with the information. Maybe they're not completely comfortable with the examination requirements or aware of the different pathways. And as a result, if you're on holiday or your local regular pharmacist is on holiday who does provide it, there might be a break in service because of compulsion or because you weren't able to get anyone else. GP surgeries also have found that the staff don't always have the right training, and it's normally the guys at the front desk, the reception staff, the reception teams, who may not be able to identify and address the right person who should be referred appropriately. Okay, and what criteria for these referral for each condition is to make that appropriate referral. And crumbs. And I guess also from what I've seen is GPs don't always have the details of the service. Like in my pharmacy, the local surgery didn't have the full breakdown of what we can do and how we can do it. And that's obviously as much as our fault as anyone else's because we're not engaged with those GP practices. But that's something that we've addressed and identified. And finally, one of the other things was need to ensure that individuals that answer the calls from patients can triage local pharmacies appropriately. So there needs to be an appropriate sort of referral network within the IT systems, be it GP or be it EMIS or System 1, for that process to occur much expeditedly, without too many steps, without too many clicks going forward. So is that's maybe something that you might have come across or maybe seen in your side as well, within your local teams or within your local pharmacies as well. So I guess from our point of view, we need to identify these barriers, whatever barriers they are, but trust in patients, trust in parents who bring this patients along to us, engaging with potentially schools, local schools, colleges, universities, places of worship, places of people where people gather, as a way of trying to, make people aware, educate, and the MPA, CPE, all our organizations which represent us or we are members of, are doing what they can do, of course. But I think also there's got to be some local sort of responsibility from the pharmacy. Nobody's going to make you money apart from yourself, effectively, or nobody's going to bring in the business apart from your hard work. And we can't forget that it's relatively a new skill. It's something which, at universities and such, we haven't really been trained up to do. It's been a very hands-off sort of profession. But now with the event of like, the neighborhood teams and the NHS 10-year plan, I think it's going to be much more composite part of our training in terms of providing this sort of first responder sort of like activity. And of course, awareness is something which we need to be made aware of. So in terms of not just our pharmacist who's there conducting the pharmacy first, but also other team members within our organization, within our group, of knowing how referrals can be made from the counter to the pharmacist, healthcare assistants, dispensers, counter staff, pharmacy technicians. We all have a part to play in trying to get the right patient in the right service for the right purpose. Okay. And that will help us, I think, build assurance and also give the GPs a level of assurance that they are able to make these referrals, and ensuring that the way they do it is in an unambiguous form, that there's less barriers towards it, and that we get the best bang for our buck for our patients, but also utilize our skill sets as healthcare professionals going forward. What's the problem? What's the risk? Well, remember, everyone, if we don't deliver, somebody else will. And you may have seen this article in the one of the journals. As a profession, we should be looking at safeguarding Pharmacy First services because it really provides us with a blueprint of what service delivery looks like and how we can build upon it. And if we lose things like Pharmacy First to other healthcare professionals, other organizations who feel like, they are just as adept in providing it, then ultimately we'll be back at, trying to save pennies on boxes of Mlodipine or bendrafluozide. I think we've got a question in the chat function. Let's have a look. Um, this event will be shared. Helen, would you be kind to, because I can't see any questions at the moment.
Yeah, there's a
Uh,
question in the Q&A panel,
oh, Crum,
and it's
sorry.
from Shangifa, who says, "We
Yes.
are getting referrals, but not enough. We have seen some of the conditions can be treated within pharmacy first, but the GPs are seeing them."
Yes. So effectively, yeah, Shingita, this is common up and down the country. They're trying to obviously not make those referrals because they think they've got enough capacity, but the truth is there are not enough GPs out there. There are not enough appointments for our patients to be seen appropriately. And effectively, it's like you're using a qualified person to do the things which other qualifications can do. So it's important that hopefully with the 10-year plan and what we're doing right now with neighborhoods and trying to integrate our services and link it all up, we will see hopefully a process where they will start doing things which obviously they have to do and also will bring them money for their sort of corporate entities and will allow Pharmacy First to then flourish. But until the sort of contracts are aligned and until these sort of things are aligned, everyone's like we did with flu jabs, like, don't go to the GP, come to the pharmacy. And then the GPs are saying, don't go to the pharmacy, come to the GP. It's an act of trying to, scrounge for like pennies and pounds and such like that. But we need to be able to have that contract alignment, I think, going forward. And maybe in the not in the next year, but the year after, I think with the abolition of what QOF will look like, it would be more outcomes based than output based. Rather than seeing patients and then getting your money through your register, it'll be actually what outcome has come out of that interaction as opposed to output. And I think with that sort of mindset, it will help move and shift work appropriately to where pharmacists can be utilized compared to what GPs are trying to gather. So watch this space, but persist, because if you're not going to be the advocate for your own business or your own services, nobody else is really going to be the advocate for you, because this is really where you come in. And like, for example, like we said earlier, if pharmacists are capable to do this for common conditions like Pharmacy First, then, ladies and gents, long-term condition management, okay, is really just the next step, the next evolution. And I'm going to be talking about how to pitch for these sorts of services. Think about your mindset. Think about how we can engage our commissioners and our federations and such, who are obviously the decision makers, but how we can actually help this process. An example is, why do they need to come to the GP practice when they can come to the pharmacy for reviewing the asthma, and where we can escalate or review and monitor their asthma in the community rather than having to be referred. And honestly, this is not like rocket science. It's about good patient care and utilizing our skills and knowledge therapeutically to make that engagement. So hopefully this will give us an opportunity to think about not pharmacy first, as my friend David would say, pharmacy forward. Okay, so what are we trying to think? Well, we need to build relationships, we'll need to build trust, and we'll need to build confidence. And this is a download from CPE, which basically shows we are in the right place as community pharmacists, our practices, our opening hours, where we are within the community. And I know there's pressure out there, and I know community pharmacies numbers are reducing, but I think we need to evolve from that. And we can't just rely on the price difference and the profit margin between buying 100 amlodipines compared to buying 1,000 or bendrafluors or whatever. We need to start thinking about other revenues. And of course, a lot of our colleagues out there are doing private services as well. But the NHS is also a good place to make money in order to make sure you're providing the right services to keep our patients out of hospital. And it's about trying to understand what their motivations are in order to achieve that sum of money that they've got, which is limited, in coming in the pharmacy direction. And once it does, we have to show outcome and not just output, not just engagement. It's about actually improving the lives of our community members. I'm going through this. You guys know this very well. And we know the clinical pathways, we know the inclusion, exclusion. Of course, it's been updated. And of course, there are plenty of resources out there that will help you as healthcare professionals about pitching not only to the stakeholders, but also to your GPs, also to your patients, also to other organizations, which are your advocates like Health Watch, like in my area, Wimbledon Guild is absolutely amazing. And trying to utilize these third sector voluntary groups and charity groups to advocate for you as well, because ultimately it's about enhancing population health within the community. So I guess from my side, how do we build these sort of GP confidence, okay? And how do we try to get more referrals? As the colleague said earlier in the question, you know, it's very hard. It's like trying to, get blood out of a stone at the moment with, they rather do the job than us, but we need to understand the strategies and the engagement. And sometimes you've just got to keep on talking. One shot will not do it. You've got to keep on making those sort of connections with your local GP practices. And there was a wonderful article written in the Pharmaceutical Journal about, and this was in August, so it's fairly recent, about why are there insufficient GP referrals currently happening? Because this in itself is hindering success. It's also hindering the potential development and escalation of what Pharmacy First can look like. And England has got only 7, but all the other Celtic areas like, Wales and Scotland and so on and so forth have got vast majority of Pharmacy First provision as part of the criteria, but their contract is completely different compared to what ours is, especially in Scotland, where they have got so many services. And to address this, what England did, they created these roles just for a short-term project base, which I was involved with, about community pharmacy PCN engagement role. And the reason why this role was there is because it wanted to find out how can we embed community pharmacists into the fabric of primary care. And when people say primary care, they still only think about GPs, and GPs are only primary care. They're not. Primary care is primary. It's GPs, it's doctors, it's pharmacists, community pharmacy teams, it's dentists, it's district workers, it's community health, mental health workers. This is true primary care, and it addresses the historical sort of disconnect that we've seen between general practice and community pharmacy, but providing a dedicated person to oversee communication training and sort of pathway alignment. And I did this for as a very low level in Southwest London, but also with my colleague David and Shelen with KCW in Northwest London. And it really kind of gave us an outlook of what GPs, what PCNs are thinking about Pharmacy First and what are their barriers, and trying to get them individually in a room or on Zoom or on Teams, finding out what would make it a success, how can we overcome the barriers, what connections can we make, what objections did they have, and I'll talk about exactly what that. But it really gives us the essential ingredients of ensuring success in rollout of this national service, like Pharmacy First, like blood pressure checks and contraception service, while relieving GP workload. Okay. So I guess the key responsibilities for this role that we undertook, it was the engagement lead really acts as a connector. It helped practices understand what we can do as pharmacists, as pharmacy teams in the community, and vice versa. It's about trying to, like when your auntie is trying to marry up this person to that person, and they're trying to act like a bridge. It's trying to get that, engagement going. And of course, troubleshooting problems like referral issues, like IT concerns or unclear protocols, to ensure that service runs smoothly and across the system. And there's a feedback loop as well. And this is the reason why it was really needed, because the role was designed to support national and regional delivery of Pharmacy First, and also addressing the primary care access recovery plan as well. And this, of course, rolls out not only for Pharmacy First, but also blood pressure and contraceptive services as well. It also was used to become a bridge of engagement between the different sort of entities that we have in our community. And by having a sort of like engagement lead for that region, that area, the aim was to facilitate a smoother referral pathway, troubleshooting, um, record sharing, read write issues, and so on and so forth. And hopefully you guys have had a chance to engage or speak to or become aware of this engagement lead that has been trying to help. And I know my colleague Shelin, David, and I were engaging quite robustly with the guys in Northwest London with Hitesh at the LPC. And I did a little bit with Mohammed in Southwest London as well. And it just gives you a sort of protocol and just someone to speak to and trying to achieve the outcomes that we need. And this role actually did matter because it allowed that sort of consistency of approach, and it aligns local pathways for Pharmacy First with other sort of CPCF services in the minds of our general practitioners and our reception teams. It also identified what issues they were having with the IT and also what issues they were having with the referral mechanism. So with both System 1 or EMIS, you know, what they can do and how to do it. And there were many videos that actually did stipulate that what processes they need to do, like how-to videos, how to make an appropriate referral. And I think one of the barriers that I came across as a result was people were saying, well, you know, our reception team is not clinical, so how would they know this is what they've got? But a lot of our sort of narrative was, well, they've been doing Pharmacy First inadvertently already by doing minor ailments, and speak to your pharmacist. And as long as it's not a red flag that they've been already trained to do, they've been doing it for many years anyway. So it really helps our patients access the services, but also ensure that the right person is being sent to the pharmacy. There's no point, you know, and I had this in my pharmacy that we had the reception sent a patient, a male patient with a catheter who had a UTI. And, you know, I just said, look, you know, thank you for sending this person, but actually it's not part of our criteria. And this was an opportunity to educate and go into the practice at that time and say, look, you know, let me tell you a bit more about Pharmacy First so you know what criteria we've got. And that crib sheet that we saw earlier with the Pharmacy First really helped identify exclusion and inclusion criteria for each of the different clinical pathways that we had. So what was our overall outcomes that we found out from this engagement lead process that I did and my colleagues did? Well, the main barriers that we identified was there was knowledge gap, okay, quite significant knowledge gap. There's apathy towards something because they don't know about it. Why should we be sending our patients to the pharmacy when we don't really know about it? So that was an educational lack of knowledge about the actual service. We also find there's IT issues because it was complex EMIS and System 1 sort of referral processes. And as a result, they weren't too sure how to manipulate or engage with that process because no one actually had shown them how to utilize it. It updates on their system at the GP level, but nobody actually says, this is how you do it. So we created a step-by-step function to do that. There's also barriers from a cultural point of view where GPs were reluctant to, like the colleague asked the question, hand over minor ailments to pharmacies because they want to do it all. The problem is, when you want to do it all, you don't have time or capacity to do the things that you really need to do. So it's like, you know, the man who's got square wheels and is trying to pull something up a hill. Someone says, look, I've got something that might help you. He goes, nope, I'm too busy to think about anything else. I'm busy pushing this cart with square wheels when the person with the round wheels is helping him. So it's a cultural change. It's a mind shift. Okay. There was also governance issues as well because they thought, well, okay, well, if we're sending our patients to you, what happens if they die, or what happens if they were incorrectly assessed or incorrectly processed? So and where does the liability lie as well? So we had to be very clear that, you know, we have got our own liability, we've got our own insurances, and MPA obviously provide insurance as well as other organizations. But as long as we work within the criteria of the PGD, we are safe, okay, because we are working within that criteria and ensuring that, you know, from our point of view from educational, like coming to these sorts of events or engaging with CPP or MORPH or any events like happening down the country, sometimes you need to go through different organizations and different training in order to really embed it into your mind. And that will help obviously from the patient's point of view, but also the GPs from assurance point of view as well. There were also competing incentives. We found that practices were funded to do some services. Like we found that in Northwest London, they were incentivized to do ABPMs. And as a result, they wouldn't refer patients to the community pharmacies. But to be honest with you, I mean, there's only so much capacity within general practice that, having a few going to the community pharmacy just to meet their needs and to identify patients with hypertension helps that patient, not because you want to keep it all, because you want to keep all the money, and because you don't have capacity, the patient goes without any diagnosis. And that's actually unheard of. And that's really, I mean, like not selfish, but that's probably more criminal than anything. Um, Yep, of course. And if there's anyone who got questions, as Helen's mentioned, please just jot it onto the Q&A. More than happy to pick it up as well. We also found another bit where patients were reluctant because they only wanted to see their doctor. They wanted to see their healthcare professional, because in their mindset, because they get free NHS prescriptions, they can only get that through the GP. But we need to change the narrative of our patients to say, if they're eligible for free prescriptions and we need to prescribe something under Pharmacy First, that they will also be eligible for free prescriptions for that intervention as well. So a lot of misconceptions, misunderstanding, but also confidence issues as well came into play, which we established from the reports that we were creating over that period of time for the project. So I guess knowledge and awareness, we know that many GPs are unaware or uncertain of Pharmacy First. We know there's inconsistencies in understanding who to refer and who not to refer. And as a result of that, that could just say, oh, we're just booking with the GP and let them sort it out. So we need to have that sort of engagement from community pharmacy with your local general practices about what you can do and how you can do it, but also making sure that signposting, we know that signposting often replaces referrals, and this can lead to underreporting. So where patients are being signposted by the surgery to the pharmacy, we need to speak to the reception teams and engage them to talk to utilize the GP systems appropriately, because otherwise it looks like it's all being signposted as opposed to active referrals being undertaken, and that's important. The IT side really was a pain because it's something which is not within the remit of us, but as long as they know how to make those referrals, and we know if we sit with them and show them how to do it, then we understand also how they're going to be empowered to be able to provide it. So that was important, but it proved an extra burden from administration point of view in order to get it done. So the heart is willing, the mind is not, in a way. And like we said, some low trust for GPs, community pharmacies, and variations in engagement. But again, this is something which just requires engagement from the general practice and pharmacy in order to overcome these negative experiences and to overcome these sort of uncertainties by speaking to them. What I've done with my local practice for my pharmacy is I attend their clinical meetings on occasions. I attend the PPG meetings. I give them updates. So, you get these AH or Alliance updates, just tell them what drugs are out of stock or when they're due to come back in, and we get that report. I think it's from Alliance we get it from. Just maybe sharing that with your general practices so that they know not to prescribe that item, or there might be a problem supplying it, and what the alternative is going forward. So it's almost like community pharmacies are embedding themselves within general practice teams as well to help with the medicines optimization, but also the management of it. And I think, I mean, like going forward with this change in structures that we're having with the ICB, with ICBs merging, and the responsibilities becoming descaled down to PCNs and integrated neighborhood teams, I think this is where community pharmacy's place can really be established by being part of that medicines management, medicines optimization teams within that practice or within that PCN, because they can tell them about what's out of stock, what's problem, what's alternative, what other things can be done to ensure patients get their medications at a timely manner. And I think this really just exemplifies what I've just said, targeting GP training, simplifying processes of referral, or telling them, showing them how to do it, showcasing success, just find out, what other things you've done and document it and just say, look, this is where success, where it looks good, and providing governance and indemnity reassurance that, as pharmacists, we've got our own indemnity, we've got our own sort of governance processes that we take place. We're not just like cowboys, prescribing left, right, and center. We do it and we align it with NICE and CKS as part what our new sort of clinical pathways will look like going forward. And we messaging framework. So we mentioned this already, sharing success. Okay. So I guess my top tips for you guys, and you're welcome to take a screenshot. It's not a problem, but it's really, don't be a one-man band. Community pharmacists, part of a massive team, so involve the whole team. Get the counter staff to become involved. Get your dispensers and your pharmacy technicians to get involved. Make sure you're ready to start from the beginning of that day, so that you're able to signpost and refer to the pharmacist from the reception, from the counter. Make sure that your dispensers go into the practices, find out how they're getting on, see if they need any help, and making every contact count. And what I do from my side, have a diary, make sure we're booking patients in, make sure we're having a chart, and we can, at the end of the month, we look at the consultations that we've done versus the number we've got on the chart, so that we know it tallies, because we know that sometimes there's differences in what we've done in terms of outcomes and output compared to what we're being paid for. From a GP engagement point of view, please spend time with the practice managers as well as the partners as well, and especially the reception teams. The one pager that we saw earlier, share it with them, go through it with them, spend a bit of time, invest that time, because that time will pay dividends back to you. And like I said, attend the meetings where you can and support each other. You've got wonderful colleagues across the LPCs, the PCNs, CPE, as well as NPA and the ICBs. So make sure that, if we're all gain, we all stand to win. If we lose, we all stand to lose. So in terms of consultation skills, so now we're going to go more about the soft skills now. So hopefully that was a good engagement part in terms of what I found, and hot potatoes, because projects just ended. But now talking about the consultation skills, make sure that we're using a very person-centered approach. Make sure that we acknowledge that you might be the healthcare professional, but the patient in front of you has got the experience and they know the story. And if you give them that golden minute right at the beginning, all the questions that you had and more will be answered already, because a patient is dying to tell you, when it started, when it happened, what are they feeling, what's different, what's changed, what's the same, what symptoms, what signs they've seen. So these sort of things, that golden minute right at the beginning, once you've established rapport, really helps give the history taking some nuance towards that. And this is all before even touching the patient going forward. We know from our history it's really about making sure that we are doing it in a structured format. And this is something that you've done through CPP and through other organizations. So please review your history taking, find out, why they're there, how long that's happened, why they're there for, in terms of the condition that they're complaining about, what other conditions, drug history, allergies, family history, and also the social surroundings. But the one that I find now is going to be more important going forward, especially with addressing red flags, especially to meet the early criteria of red flags and patients who are deteriorating, is using SPAR. SPAR is super relevant, because once you identify someone who is not appropriate for your services but needs to be escalated to a hospital or A&E or paramedic, use SPAR as a way of a structured communication, and also helps give the person that you're speaking to a way, understanding of what you're thinking, and then also know what to expect as well. It also helps give you a structured way of trying to understand what needs to be addressed quickly and what your concerns are. So S stands for situation. What's the situation? What are they presenting with? What's their background? Okay, what other things are you have got concern about? What are the comorbidities they might have? What are the medications they might have? And what signs, symptoms have really affected, really pinged your mind in terms of red flags? What assessments have you done? What breathing? How often they are, like there was the breathing rate, the temperature, blood pressure, all these sorts of things, pulse, okay, and how they're looking. Are they stooped up? Are they unstable? Are they confused? And what are your recommendations? I think this person needs to be seen pretty promptly, or this person might need to actually see A&E, or I think we need to get an ambulance down, or I think this person needs to be seen by a sexual health clinic or any other provider. So it really gives you a structured way of trying to address it. So if we employ this as part of our sort of acute otitis media, okay, I'm going to go into the clinical part of otoscopy, okay? We know the ear is a beautiful organ, okay? And we're going to employ our consultation skills to a particular person with potential acute otitis media. So very briefly, the ear is made up of three main parts: with the outer, the middle, and the inner. And whilst the external and the middle ears are mainly concerned with transmission of sound coming in, captured by the pinna into the ear canal and then goes to the inner ear. Uh, the inner ear is where the actual mechanism of converting those sound waves to electrical impulses that we perceive as sound. But it also houses, the inner ear also houses organs of balance as well. So let's have a look at the first two parts, which will be pertinent to what we do as pharmacists in the community. So when we decide we're going to examine the ear, okay, if someone's coming in and they're tugging at the ear, or it's a child tugging at the ear, not eating very well, not being their normal day-to-day playful self, and the parent or guardian has said, something's not quite right, what we're going to look at, well, we're going to sit back and we're going to look at the ear first. Okay, so when we do our physical examination, we look back at the ear first, make sure it's consistent. So look at the different structures. So on the outer side, you'll see you've got the helix, and then the helix is then moved down, okay, down to the lobule being the earlobe, very soft. Okay, opposite the helix, we've got the antihelix, which is the inner fold inside the actual cartilage of the ear. Okay, and then on the outside we got the tragus, which is very thickened cartilage area. Okay, does it look normal? Does it look consistent from your left ear to the right ear? Okay, and we observe that. Okay, and we've noted down as well on our clinical documentation. Now we know with the pinna itself, which is the whole actual structure, because it's external, it's usually pinned quite closer to the head, but it can receive little or no damage if it's flattened against the head under pressure. But we know that continuous sheets of cartilage sometimes cause a problem, especially if there's damage or if there's any physical trauma, and the whole structure of the pinna can be broken down, leading to permanent deformities, like you see in boxers or in people who play rugby. They usually get these cauliflower ears. Okay, and we know the different structures. We've seen that when we looked at it, we observe all the different structures that we get. Oops, crumbs. Yeah. And then we look at the actual ear itself, okay? And we look at if there's any sort of infections, inflammation. We look behind the actual pinna as well to see if there's any inflammation behind the ear, as well as any scarring in front of the ear as well. So having a look around the area helps identify if there's any other issues going on behind the ear of the pinna, and also adjacent to the targus on the outside as well. And this is important to document as well from our clinical documentation point of view. You'll see behind the ear, there's a mastoid bone. This is a very hardened bone, very prominent. And sometimes in patients with acute otitis media, this mastoid bone gets inflamed. It's called mastoiditis, and this is a serious, super serious infection. It's not very common, but it's common in children, which is caused by acute otitis media and has again progressed. So we've got to catch it early, and this is obviously a red flag that needs to be addressed, and of course, with the criteria, we would need to make sure we speak to the parent or guardian, and that this patient would need to be seen pretty promptly. So once we've had an examination of the skin surrounding the area, once we've seen any sort of no skin lesions, the color is consistent, there's no infections or inflammation, and it's as we would expect, we would then proceed and we want to look at the ear canal. Now, look at the ear canal. We utilize obviously our eyes first and foremost. Okay, we don't start digging in as if we're trying to mine for gold. This is not bitcoins, but we're trying to ensure that we are looking from the ear canal going down if there's anything else that we can see. And all we just need to do is really manipulate the pinner, moving it in order to be able to have that sort of clear view line of the ear canal. Now, the ear canal is very narrow. Its average is about 25 millimeters long and about 6 millimeters in diameter for an average adult, of course, and is closed at the medial section by the tympanic membrane. Okay, so the eardrum at the back it closes that ear canal. Now, the main function of this ear canal is super amazing. It helps with the sort of conduction of the sound, which is collected by the pinna going downwards. It also helps with the enhancement of the sound because it's surrounded by a bony structure on the surrounding area, so it amplifies the sound coming in. It also protects against foreign bodies as well, and also protects against fluctuations in temperature as well. Okay, so very functional, very important for its ability to be utilized in a correct for its function going forward. Now, when we're looking at the ear canal, okay, we have to make sure we use the right speculum. Now, the speculum is obviously the actual bit that slightly protrudes inside the ear, very slightly, that is attached to the otoscope. And we've got to make sure that we're using the right ones. For children is usually 0.2 to 0.3 because of the very narrow ear canal that kids have. For adults, could be anything between 0.4, 0.5. But of course, the right size for the right patient going forward. And sometimes young adults might have very narrow ones. Older children might have slightly larger ones. Just depends on the anatomy of that individual. And when we're looking at it, remember when you're holding on to the actual otoscope, you don't use it like a hammer. Okay, we're not trying to like dig away, but more like a pen. And when we're using it like a pen, all you want to do is make sure that you pull the pinner back to allow the sort of view of sight within the ear canal to be nice and clear, and then you're able to identify the actual ear canal and look around it. What are you looking for? Well, you don't have to go too far. You want to look for any inflammation, infections, foreign bodies, okay, or any exudate, okay? And that usually, you don't need to go too far in. You can just pull it back and you can actually see quite clearly. You can use your otoscope, but you don't need to go too deep in order to see your ear canal. Now, some individuals obviously have very narrow ear canals, some individuals have very wide. So it really depends on that individual in front of you. Now, with children, especially children who are excited, nervous because they've come to see you and they see you've got an otoscope, you've got to reassure them, say, hello, little Mary or little Freddie, how's your day? What's your favorite, dinosaur or what's your favorite toy? Keep them calm because ultimately, if they see you coming at them with the otoscope, they're going to get nervous. They're going to move around and the parent or guardian is going to have to put them on a proper headlock. But there's a way to actually seat them. They need to be sat at right angles on the lap of that parent. So their ear that you're going to examine needs to be on the outside. Okay, always examine the normal ear first before you examine the affected ear. And then what the parent and guardian would have to do is use one hand to cradle the head down so that they're not moving around, and the other hand to cradle I'm going to show you on me, cradle the body so they're not lashing out to the person who's conducting the otoscopy. And that just keeps them calm. But also make sure you're speaking to them nicely, make sure you're reassuring them and say, wow, this is amazing. And not coming at them with the otoscope and just sticking it in the air because that will traumatize the child to no end. Of course, then they would move around and then the parent would then, guardian would then cradle them on the other side, exposing the other ear for your viewing pleasure. It's important that when you're looking and you're looking further down into the actual ear canal, you're not leaning on that individual, okay? You need to be able to hold it quite strictly. I tend to use my pinky finger and light on top of the actual cheekbone, because if the then child starts moving, they're not able to cause damage, because you could actually inadvertently cause damage if they move towards the actual otoscope. So use your pinky finger as an anchor. So if the child moves, you move as well. Top tip, very easy to do. Now, with otoscopy, as you can see in the picture, if you're going to examine the right ear, you have to use your right hand, okay? And holding it like a pencil with your pinky finger against the cheekbone of that individual, or at a certain distance, so that they don't move. You can see where the handle is in the same direction as the nose. So right hand, right ear, left ear, the handle according to the nose, holding it like a pencil. Using your other hand, which is free. So in this case, the person's got their right hand using the otoscope, and the left hand manipulating the ear canal by moving their pinner back. So for adults, it's usually up and back, because obviously with age we have more meanders in our ear canal, whereas children is mainly just back, and you'll be able to see the ear canal quite clearly. Now, there are specific otoscopes you can use, but that I'll refer you to the NHS guidance for that. So in terms of what we're going to be looking at, what does normal look like? When we're looking at the tympanic membrane, okay, the shape is a sort of vertical ellipse or an oval shape, and it's a very thin membrane, no more than 0.1 millimeter or so, so really paper thin. But the membrane is at an incline at about 45 degrees. And this helps us to see the landmarks when we're looking through the otoscope. And the landmarks are important, because when you talk about landmarks in your documentation, it tells you which area that you're trying to identify, okay? So we can see here quite clearly, you've got your pars flaccida, you've got your pars tensa, the pars flaccida, which is covers about 20 to 30%, and that's the one that moves the most. The pars tensa, like the drum of when you play drums, is the tense part of the actual eardrum. Now, the pars flaccida, if you go down, has a handle malleus going downwards straight to the southern point, which is called the umbo. Okay, you will note from the umbo there is a cone of light emanating. Now, this isn't any light coming from inside the ears. No, it's your reflection from the otoscope that you've got. And the reason why it's called a cone of light or light reflex is because, like in physics, when you've got a slight depressed area and you shine light on it, the line spreads from the center outwards. So that's why it's all about how the membrane is slightly depressed, because it's concaved as opposed to convexed. And this is what gives it the cone of light sort of attribute. It overall, the membrane itself is of pearly gray color, okay, and it's displayed like a sheen, like a mother of pearl, okay, for those individuals. You can see, and of course this varies from person to person, but generally speaking, this is the kind of depiction of what a normal tympanic membrane would look like. Okay, now we mentioned, of course, the landmarks that we've got. It gives you a sort of like an area that you need to then identify and say, look, pars tensa, normal, landmarks seen, no infections, no inflammations, no perforations, is what you'd see like in the picture on the right hand side. Let's have a look. So we know the thing with differentiation, and the problem is, everyone has got differences, so we need to be able to compare what the left ear looks like compared to the right ear and vice versa. But it also changes from person to person, and this is like my way of saying, like, if it's got feathers and flies, it could either be a pigeon or a duck. So the more experience you get, the better it is. The way I've done it with my community pharmacy teams and the group I work with is, if a patient's been diagnosed with having some sort of ear infection, and they come to you with a prescription, get your otoscope out and have a look and see what the doctor saw and compare the images. The more practice you get, the better you'll become. And you'll be able to distinguish and differential diagnosis between, say, acute otitis media versus acute otitis externa versus, wax versus other things as well going forward. But I've got some lovely pictures, which I hope you've had your breakfast already, but what different things look like. So this is what normal presentation looks like, okay? And before we get to the pictures, our assessment is kind of things that we need to ask. So we need to find out from our patients, when did it happen? When did it start? How severe it is for that individual? And when you talk about severity, is it debilitating where they've got to stay at home, they can't do the things they normally do, or is it annoying? And there are certain issues and pains that you can live with and get on with your day-to-day life, but there are certain ones that you can't, that restricts your ability to do your day-to-day functioning. So find out about pain, tenderness. Do they get pain when they move their jaw or their ear? Is there any discharge? Is it itchy? Is there any fever? Is there any hearing loss within that affected ear? And does it affect the quality of life? And then find out and establish what potential causes behind those issues could be. Like, have they been swimming lately? Have they been on holiday lately? Was there any trauma to the ear? Do they use hearing earplugs or hearing aids? Have they had any sort of like radiotherapy recently or chemotherapy? Have they had any surgery or perforation where they're using earbuds? Is there any allergies that they've got? And this will help identify these individuals from what normal looks like to what they're presenting with as well. So here's an example of what they see in acute otitis media, for instance, okay? Like I said, apples and pears, you might not always see the full thing, but generally this is what media looks like. And we refer back to our clinical pathways, okay? And our clinical pathway says, apart from looking from the ear canal, look at the actual tympanic membrane, okay? Look at the pinna, look at the area around the ear and behind the ear, and look at any nodes to give you any sort of signs and symptoms of active infection as well. Is the tympanic membrane red? Is it inflamed? Is it swollen? Can you see any debris? Can you see any discharge? Can you see any signs of any fungal infections, like, for example, strands of candida or small black spots or white spots? Can you see any sort of infections leading up to the actual ear canal or beyond the ear canal? Okay. And also check if you can see the normal landmark. So we mentioned about what normal looks like. In this example, you can see that this is not a concaved tympanic membrane. This is a convexed. Okay, it's bulging out. You can't see your cone of light. You can see the handle of Malus going down there. Okay, you can see the umbo, but it's not in the place that you'd expect, and there's certainly no light emanating from there. And the light is mainly on reflection from the actual bulge from the tympanic membrane. So it's bulging area and the absence of normal landmarks, okay? And this would be present with patients who complains with an acute onset of ear pain and typical with what you'd see in acute otitis media for these individuals. So for example, from our criteria, we know our exclusion, right? We know it's for patients under the age of 2, but over the age of 1, if they got both ears, okay, and there are symptoms for more than 3 days, under the age of 18 with otorrhea, so they're getting discharge, and also signs and symptoms of acute otitis media that we advised already. So have a look at the NICE CKS on acute otitis media. That link will be on your new proformas. We know with children, they usually come in presenting with an earache, but in younger kids, because they can't articulate what's going on, they might be holding it, tugging it, rubbing it, not feeding properly, not doing the things that they normally do, crying more, so, and also quite restless. There may also be a behavioral change, maybe having runny nose as well going forward. So then we would then also check out from a confirmation of diagnosis with an otoscopy. And then what we would see would be distinctly red, yellow, or cloudy tympanic membrane, because remember the membrane is super thin, paper thin. Normally like we said, it's the color, mother of pearl. But for those individuals who've got acute otitis media, it might be red, it might be cloudy, it might be yellow, because it shows that there's an infection behind it, like a balloon almost bulging out, there's something behind it that's pushing it out that way. And there may be a bulging involved so that you lose the sort of normal landmarks that you normally see going forward. Okay, so these are the individuals that you need to address quite quickly and quite readily to ensure that they're getting the right therapy going forward. We know also from an exclusion point of view, we know that, anyone who's under 1 or above the age of 15, immunosuppressed people, individuals who are on long-term antibiotics or on previous antibiotics for previous episodes of acute otitis media, and also those people who might have suspected foreign bodies in the air as well. So maybe something's crawled in, or something's like a hearing aid battery, or something's got stuck in there. We would exclude them because they would need referral for review by an ENT specialist. But also anyone with a temperature over 39, patients with suspected meningitis or mastocytitis, so know the signs, know the symptoms of these two. Okay, so meningitis, stiff neck, photophobia, mottled skin, mastocytitis, pain, soreness, swelling, tenderness behind the affected ear, not eating, not drinking. We need to check it, and you can see the difference between the left and the right. Also, anyone who may have a risk of any sort of abscesses, especially intracranial abscesses, they might be getting severe headaches, confusion, irritability. They shouldn't be coming to your pharmacy anyway, but really and truly, these guys are direct up for referral to secondary care and A&E. Anyone with paralysis, dropped face, drooping face on one side, could be a stroke. We don't know, but we need to get these referred on pretty promptly, because that problem is more severe than the acute otitis media that they think they've come in for. Okay, so there are, these symptoms, and we've seen it. So what could the differentials be? And this is important, where we see, what's the difference between a pigeon and a duck, for instance. Okay, so here's some common differentials that we might come across. Okay, so we might have someone with acute otitis media with effusion, where this is effectively called gluea, and these individuals tend to be mainly young kids. They don't have any symptoms, but the parent has noticed that they're not listening. They might be hearing loss. There might be behavioral problems because they're not listening. And the parent thinks, or the guardian thinks, that they're not listening because they're being naughty, but actually they're not, they can't hear because the actual, not the actual fluid buildup within the actual, behind the tympanic membrane, is precluding the mechanism of sound conduction going down to the inner ear. And what you would see if you did a otoscopy for these individuals, you'll see a sort of dull fluid level behind the actual tympanic membrane. Instead of being translucent, it might be opaque. There won't be any effusion. They might have had previous sort of perforations because they get it recurrently. These are the kind of guys who probably need grommets being fitted in, because if they have ongoing infections and ongoing sort of gluea, sort of like inflammation, then it could impact on their hearing long term, but also on their learning and speech development going forward. Sometimes with these individuals who have got gluea and they get reoccurrent sort of perforations going forward, obviously, like any balloon bursts, and then depending on how that burst occurs, could be a partial or it could be a complete perforation of that tympanic membrane, or it could be as a result of a trauma where someone's been sticking a sharp instrument because they got itchy ears, or cotton bud. And that's important to note, that a perforation has been identified, that we should not be giving any eardrops of any kind to that individual as a result of irritation to the inner ear functionality, so that barrier has been compromised, and we need to safety net that in individuals going forward and be seen by ENT or by the GP, because they would need to have appropriate escalation. Normally for kids, perforation can heal up within 4 to 6 weeks, so it's pretty quick. But in older people or people with comorbidities like diabetes and such, it could take a lot longer. If they got hearing aids, it could take a lot longer, and in fact can impact on their risk of having subsequent infections as well, because of sugar levels, because of all these other immunocompromised issues that might worsen their outcome. But definitely these individuals with perforations, don't submerge their head in water, or they shouldn't go swimming or getting water in their ear going forward. Otitis externa, yep. So this is mainly an inflammation as a result of infection, mainly usually up to due to a fungal infection, and it's estimated that 10% people will develop otitis externa in their lifetime, and this is increasing as we're wearing these sort of headsets or wearing earpods, or people wearing um, hearing aids, or going to hot tropical countries where they swim in hot moist areas. So it's a very common presentation that we would see in the pharmacy going forward. And like we said, the risk factors are because of common sort of issues, but also it could be due to individuals who've got things like diabetes or eczema that could be the precursor to acute otitis externa going individual. Um, Proportion of it can be fungal, but sometimes it could also be bacterial as well. But of course, this is not our thing to address. It needs to be assessed by the GP going forward, because they would probably need a course of antibiotics and potentially oral antibiotics, depending on the severity. If left untreated, can cause itching, discharge, and hearing loss going forward. Now, cholestoma, again, another red flag that requires further escalation to GPs. Cholestoma is not really to do with tumor, or it doesn't have anything to do with cholesterol, but really it's an accumulation of benign keratinizing squamous cells. So it's basically cells that are producing in rapid format, but it's not cancerous. But what it can cause is pouches and pockets of risk of infections behind the actual cell's growth, and thereby giving that patient sort of recurrent pain, discharge, and fullness in the ear. But it's typically painless that individuals can get, but increases the risk of infections and furthering those sort of infections and necrosing. If left untreated, can cause necrosis to the surrounding tissue, which could mimic sort of malignancy as well. So this needs to be seen and addressed because of the risk of hearing loss and recurrent infections, which can spread to the rest of the structures around the ear. We also got tympanosclerosis. Now, tympanosclerosis is a person who has had recurrent perforations, healing, perforations, healing, perforations, healing, and it's basically the scar tissue that's left on the actual tympanic membrane, and usually it's presented as a chalky white appearance of the eardrum. Because the eardrum is now compromised, the tympanic membrane is now compromised, it can lead to conductive hearing loss, which basically means your thin membrane has not become thin anymore, it's become more thicker. So not all the vibrations that are being conducted through the pinna, from the pinna to the ear canal, can get through the inner ear. And as a result, people can lose hearing. And sometimes individuals can get pain, or ear pain as well, which is not as common, but can happen. Now, if it affects your hearing, it affects your eardrum specifically, it can worsen the development of that individual and quality of life, as you can imagine. But especially if patients got issues with the drums. Yeah, lots of information to take on. Sorry, guys, but yeah, you know what? You guys know this. I know you guys know this because it's been going on for a bit longer, but hopefully this is more of a refresher. But please do ask questions. Look, there's no such thing as a silly question going forward. Yeah, I'm just showing you the differentials between what you might be seeing going forward. So please don't think you can't ask questions, okay? Our wonderful ear wax, okay, also known as Suramin. Okay, now Suramin, as you can imagine, is natural. Okay, earwax is absolutely natural. It cleans, it protects, it lubricates your external auditory canal. Very important in what it does, because it's an natural anti sort of biotic. It's antiseptic, antimicrobial, everything. But the problem is, impact can be diagnosed for patients who obviously are trying to get rid of it using earbuds, and they cause that impaction, causing a cementing format almost, which can preclude the sound waves moving down the ear canal to the eardrum. As a result, person can have hearing loss as well from that point of view. Okay, so it's important that we don't use implements to get rid of our wax because it's natural. And the body is quite funny because the more you try to take out with cotton buds, the more it produces because it thinks like crumbs. It's not there anymore. Let's produce more, and it goes again. And crumbs, it's not there anymore. Let's produce even more. So almost like it's a negative cycle, a negative feedback loop, where the more you do, the more you have to do to get rid of it. Don't do it. Okay, utilize things like sodium bicarb, olive oil, especially those individuals who might have hearing aids and such. They're more likely to get excess wax production because of the humidity that's being caused, increasing the risk of infections, increasing the risk of microbial and fungal sort of interventions. So the body's just trying to create defense. Like when you produce mucus in your chest, when you get a cough or a viral infection or bacterial infection, the ear produces wax in order to stop the progression of any infections and helping it move out. So it's just a body's own response. But so if you have those guys who are doing microsuction and such like that, I mean, it's important to have that education with our patients going forward as to why they're getting the process of excess production. And of course, foreign bodies, there's been cases where, people have left things, parts of cotton wool, cotton buds, but also here's a battery from dislodged ear aid, hearing aid, but also, depending on which part of the country and how rural you are, this is a cockroach, a small cockroach trying to embed itself in someone's ear. The way, obviously, we wouldn't have to do anything with this would need to be referred, but the way they would get rid of this cockroach is obviously they would put a little bit of alcohol in there, suffocate it, kill it, and then remove it gently. Because if you imagine something which is still alive and you're trying to remove it, it's trying to crawl back in, and those legs look really sharp. So I don't think they want it alive, they want it dead. But also, and I know kids are putting everything in everywhere, like up their noses, they put peas and toys and little things, so it can go in their ear as well because that's what kids do. So, don't be surprised to see these sorts of aspects. So from a red flags point of view, so we're going to have a quick discussion, okay, about red flags and how we can address it. And just put your mind back to our structure that we have in terms of how we're going to organize our conversation when we speak to our patients early on. Let's have a look at the criteria. Okay, so when might we want to refer to A&E or another healthcare professional because it's out of our remit? So this is a little comparison between the previous 1.6 version on the left and the new 2.5 version on the right. And as you can see, it's escalated by you can have a gateway point, achieve a gateway point if you identify patients who are considered at risk of deterioration, who have got a red flag or have got a serious illness, who are presented to you. So, ladies and gents, in many ways, red flags should be addressed quickly and promptly and competently, because you will get something back for it by achieving a gateway point and signposting that patient appropriately to A&E or calling 999 because of a life-threatening emergency. And I think this was the right thing to do, I'll be honest, because, and this is in all our criteria now from the 1st of October onwards, where if we are able to identify these red flags earlier on competently, we will be rewarded for it, because then that means we're not educating ourselves just so that we can refer the patients onto a hospital, but we're doing it pragmatically and responsibly as well. So I think this is a good thing going forward. But of course, it shows our inclusion criteria, excludes our exclusion criteria going forward for these individuals. So any presentation other than acute otitis media, we must safety net and we must refer onwards appropriately. And if they meet the red flag or the deterioration or the serious illness category right at the beginning, then we need to document that in terms of what we've seen, what are the signs, what are the symptoms, what are the observations, what News2 scoring we've provided them with, because it will all be composite of our clinical narrative in order to be eligible for that criteria gateway point. Crumbs, let me move out. Okay. So have a quick look now. What it is basically saying is that we're trying to ensure that uh, we're excluding people with 3 or more episodes in the last 6 months, or 4 or more episodes in the last 12 months, pregnant individuals under the age of 16, acute otitis media affecting mainly, as we know, children, can last around about 1 week, and over 80% of our children who have been affected recover spontaneously without the need of antibiotics. So that reassurance is very important, that we reassure not only the patient, the child in front of us, but also the parent or guardian who's brought them in as well. So any presentation other than acute otitis media that comes to us, we need to make sure that we're safety netting them using USE2 scoring, and making sure that we're using SBAR, like we said earlier, SBAR, to refer that patient onwards to the appropriate clinician. So when we're looking at our red flags, what could it be? We have to show that any sort of red flags, such as suspected meningitis, where they get stiff neck, photophobia, mottled skin, mastoiditis, which is pain, soreness, swelling, tenderness behind the ear or the affected ear, any sort of brain abscesses, which are severe headaches, confusion, irritability, sinus thrombosis, which is headache behind or around the eye and eye orbital, and any sort of facial nerve paralysis. All these aspects we really need to identify first and become comfortable in talking to that patient, and excluding the red flags. Exclude these red flags in order for progression going forward for the next stage. And when we refer, like we said, using people who are systemically unwell or have got signs and symptoms of all these things, but also looking at sepsis, and the things that we mentioned earlier, it's pretty high risk stuff, but cool mind, cool headed, and approach will then signpost the patient appropriately. But document what you've seen, what the patient has told you, what you've observed, what sort of observations you've made as well, through blood pressure, pulse, respiratory rate, gait, how they're feeling, temperature. All these things will then help with that sort of criteria going forward when you're doing your SBAR. And here's one that I've copied from a different resource, but really useful in the sense that these are the red flags that we would need to present to their GP when presenting any of these following symptoms going forward. So there's two main sort of aspects. One was, people who would need to be seen by A&E or a paramedic quite urgently, because of the risk of detriment of their health going forward. And those individuals who may not completely meet the need for A&E observation or paramedic use, but can be seen by the GP within the day, within the same day or the next working day. And again, this is where SBAR comes into play. The patient's got temperature, they're hot, shivering, they're vomiting, they're aware of what's going on, but they're just feeling very unwell. This really needs to be seen by the GP practices. So be aware of your different level of referral. One is like urgent here and now, A&E 999, and the other one is GP, ideally today, if not within the next 24 hours, or NHS walk-in service, or 111, which is not urgent, it's not life-threatening, but needs to be addressed within the 24-hour period. And when we're looking at our gateway points going forward, okay, assuming that they don't have any of those issues, then we can then progress with, well, do they need an otoscopy examination? Do they meet the criteria that they could potentially have acute otitis media? And if so, then what are we looking at? We're looking at older children and the presentations, younger children, and younger children without specific presentations as well. And then what we would be seeing in terms of observation is on that right-hand side, distinctly red. And if you don't get any of these aspects where you're not seeing the signs, but also the symptoms, then it's unlikely. Then it potentially could be an alternative prognosis, which doesn't require intervention. You're not there to diagnose that individual. If it's not acute otitis media, pass it on. But if it is very likely to be acute otitis media, then we need to find out, like we said, as antibiotic custodians and antimicrobial stewardship, that we're not just providing them with the demand of an antibiotic straight away, but we're telling them that it's more likely to be acute otitis media, but it should be symptom control, symptom management through pain relief, and lifestyle, and not going swimming and such. Because that's more likely to help resolve it. 80% of our patients will be perfectly fine with that sort of approach going forward. When we're looking at patients, like we said, if they are systemically unwell, if they are showing serious signs of symptoms or illness, or at high risk of complications because they've got comorbidities, and this includes children as well with heart, lung, or renal issues that might compromise their health or immunosuppressed, then these individuals need to be seen by the GP because it's a better place for them. But if they don't have any sort of aspects that, although it's very likely to be acute otitis media, but they don't have any higher risk aspect towards that acute otitis media, then we can then proceed with seeing them within the pharmacy going forward. So from onwards, the patients, we would then observe them, have they had otorrhea, if there's any discharge, but also look if there's any perforations in the eardrum or suspected or confirmed perforations. If they've got perforated eardrums, suspected or confirmed, okay, then we can offer them an antibiotic, okay? If the symptoms are not resolved, we can offer them an antibiotic. Now, the reason why I say suspected or confirmed, because sometimes you can't see the eardrum. You just cannot see it because either it's difficult or there's wax in the way or there's exudate and it's coming out. So if there's a suspect that this eardrum could potentially be uh, perforated, then we can't give them an ear drop. We have to give them an antibiotic. Now you might say, Darshan, how do we say that? How differentiate whether or not a person's eardrum is perforated without actually seeing it? Well, you could find out if there's any hearing loss. You can find out if there's been a sudden discharge onset, which has caused that with maybe a little bit of blood coming out of it. Sometimes the discharge may not come always from the actual eardrum being burst, or it could be coming from surrounding areas. But if it looks gray and it's got a trunk, it's more than likely to be an elephant more than anything, but it can be other things as well. So it's almost, if it's suspected, it's more likely that it is perforated. I would go for an antibiotic. So amoxicillin 5 days. If they're of course allergic to amoxicillin, we can give penicillin, clarithromycin, depending on if they're allergic to penicillin, we can give them, clarithromycin going forward. So it's important that we identify these individuals. Now, if the person does not have, if the child does not have any sort of severe symptoms, and the symptoms are 3 days or less, then it might be worthwhile trying to give them Autogel as ear drops, 4 drops, 2 to 3 times a day, up to 7 days. And that individual would then benefit from having something because they're not perforated. But if the child is not under 2 uh, uh, and does not have bilateral acute otitis media or otorrhea or a perforated eardrum, then if they got mild symptoms, then yes, self-care. Moderate to severe, then we can consider giving them Ortigo going forward. So we want to try to reduce the impact of using antibiotics because ultimately, I'll be honest with you, it probably won't make any much difference to their outcomes going forward. And it's really about symptom control. But safety net, safety net, safety net, safety netting, advising the patient if the symptoms worsen rapidly or they become unwell or do not improve despite having the therapies that you've provided them with. If they have been given antibiotics, then they need to then seek escalate to further advice with the GP. But if you find that you've given them or ear drops and they haven't resolved, they can return for reassessment if there's no improvement after 3 to 5 days. Okay, so it's important to have that written down and write it as a plan. When you give them that target leaflet, write it down as a plan so the patient expectations or the parents or guardians expectations is also being managed. And that pamphlet, the target pamphlet, is super useful because it takes the pressure away from you. It takes away that, oh, it's the pharmacist saying no. No, it's not the pharmacist saying no. It's more likely that it's more of a viral infection or a mild bacterial, which will resolve in itself going forward. And it manages the expectations of that parent or guardian, but also the patient as well. So you say you should be fine, but we'll catch up in about 7 days if necessary going forward. So please utilize the resource. It will be really beneficial going forward. And when you're looking at advice, paracetamol, ibuprofen where appropriate, if it's not contraindicated, i.e. they can go to like asthma or anything or gastrointestinal issues. making sure that they place either warm or cold flannels onto the ear, which will help keep the area calm, reduce the inflammation. Using cotton wool just to remove any sort of external discharge, any discomfort, and manage their expectations. Say to them, like, there could be a risk of perforation. It's like a balloon that bursts. It tries to get rid of the infection, which is a good thing. So if you find a little bit of blood or a little bit of yellow discharge on your pillows of the child early morning, it could be as a result that is perforated. But this is not a danger. Like any part of our skin which gets compromised, it heals up. Okay, and that will give the child so much better sort of outcomes as well, because it's got rid of the infective component naturally. But normally the body does its own thing, as you know. And we also know not to insert anything in the ear. Don't allow water or shampoo into the ear, because it can worsen the outcomes. It can dry the area. It can compromise the tympanic membrane. And don't use decongestants or antihistamines because of lack of evidence behind it as well. It doesn't help. So in terms of case studies, let's apply your clinical knowledge to your consultation skills as well, and how we're going to build confidence in our GP practices in our patients as well going forward. So have a look at this case study. Okay, you've got here a patient who comes to you, an 18-month-old child brought in by mom. Child is irritable, tugging both ears. They're not happy, not eating properly, quite miserable, quite a little bit feverish, and they're irritable. Okay, you see the signs. Okay, they're irritable, they're fussiness, they're moving around a lot. Okay, and like I said, now they're tugging at the right ear. Okay, so mom and dad or parent guardian was saying they were tugging both ears, but actually they're tugging the right ear mostly, holding on to it and saying, I'm not happy. Slight fever, 37.8, nothing to write home about. But this patient has difficulty in hearing the right ear more so than the left. Okay, so what are you going to do? Well, hopefully you've got a bit of information. This patient is coming in. This age group is criteria is appropriate. They've been potentially referred to you by the GP practice, the reception, because there aren't any appointments available, and mom, dad, parent, guardian, they're just worried about the child, so they won't get the child seen ideally straight away, because they've got to give it to the childminders, and they need to go to work, whatever the situation is. So you think, okay, no worries. This is a bit of a history. There's no other conditions the child has got, healthy otherwise, enjoys Teletubbies, whatever it is. Okay. So you say, okay, let me have a look in your ear. Let's have a look. Okay. You don't go grab them and say, let's have a look in your ear, and just like, as if you're poking it. Distract them, get mom, dad, parent, guardian to hold them as you would do. Look at the normal ear first, the one that's unaffected, your left ear, and then look at the right one. Okay. And they would need to be sat appropriately on the parent guardian's lap in order to do so. And this is what you see. Okay. What do we see here? Yeah. You can see a bit of exudate, okay, on the left-hand side from the outside. So it doesn't require much otoscopy. Just by looking at it, you can see there's a sort of gunk coming out. Okay, there's no sort of debris, but it's quite gunky. You can see it. It's a bit red, probably around where the child has been. Look at the pinna. It's a bit red. The child's probably been tugging at it or holding it and such. Okay, and what do we look inside? Okay, let's look a bit further in through the keyhole using the appropriate speculum and say, don't worry. Let's have a look. Let's have a look. Okay, be gentle. Get a little teddy bear that they probably brought with them, or some sort of distraction. Mom, dad, parent, guardian might have a phone. Just say, look, your Teletubbies is on. So they're looking one way and holding them. And then you can see the tympanic membrane. Okay, a little bit of discharge there, but you can see clearly here what was normally a concaved membrane is certainly convex, meaning it's bulging out. Okay, it's a bulging tympanic membrane. Where are the landmarks? You can't really see the umbo properly because it's been hidden, and from that you can't see any sort of cone of light. You can't see the pars flaccida properly. Pars tensa is inflamed. It looks a bit yellow. Normally it's quite grayish, like we said, pearly sort of coloration. It looks a bit yellowish to me at back, if you can see. Okay, looks a bit red on the top, a bit red. So it's erythromas. It looks like slight infection. It's definitely bulging out. So there's something going on behind that tympanic memory causing it to bulge out. So it certainly looks like there's something else going on there. Okay. So document, document, document. Say what you see, like catchphrase. Okay. Say what you see both from externally and then when you're using your otoscope, and part of that shared decision-making process. Make sure you're saying, is it okay if I do this? For me to gather more information, I just need to look in your ear to ask the parent, the guardian, ask permission of the child as well. Say, look, I'm just going to have a quick look, have a look at this whilst I look in your ear, get them familiar with it. This individual potentially could utilize amoxicillin, okay, depending on how bad it is. Now, we mentioned about mild, moderate, or severe. The parent is obviously worried. There's temperature for this individual. There's slight difficulty in hearing. Okay, they're not doing the normal day-to-day functions. They're not enjoying what they normally do. They're crying, they're irritable, they're not eating. I would put this probably in the moderate stroke severe category, and that's why I would give antibiotics. Okay, if the patient was fine, playing normally, and saying, "Mom, Dad, it's hurting a little bit," but then forgets about it and plays Call of Duty or whatever kids do these days, I'm not sure, but starts going on the computer and doing the things without any issues, that would more likely be mild, even with a similar presentation. So it really depends on the patient's presentation that's before you. Okay. What we do, yep, I would give antibiotic for this individual 5 days if they're not allergic to penicillin. If they are, then obviously clarithromycin. If the symptoms worsen rapidly or significantly, I would advise the parent or guardian of this young person. They become very unwell, or significantly do not improve despite antibiotics, then they would need to be seen by the GP 2 to 3 days later. And our role is really there about counseling, reassurance, and emphasizing about completing the full course. Because if you're going to take an antibiotic, take it properly, making sure that pharmacists are advising on dosing of other sort of supportive mechanisms like paracetamol and ibuprofen if appropriate, not to submerge the head if there's a slight perforation, not to put anything in the ear, and making sure that if this patient wasn't too bad and we gave, for example, the eardrops or Otiagio, then if it doesn't improve within 3 days, then they should come back and see us. Okay. But with an antibiotic, there's nothing much we can do. If it doesn't improve, they would need to be seen by the GP. Okay. And also review the patient on how they're getting on in terms of the day-to-day functionality. So this helps with our gateway point because obviously we've managed the symptoms, we've seen it, we observed it, we've given them the therapy, we've observed also the otoscopy. So we've seen the signs, the symptoms of acute otitis media, and thereby being likely, because of the observations we've seen, we've managed that individual going forward. So I'm going to ask you a few questions. So hopefully you can put it onto either the chat or the Q&A. Okay. What are the signs and symptoms, okay, of middle ear infections, otitis media? So I'm going to kick you off. Earache, okay, but specifically in young children, what else might you see? Yeah, and if you can put it on the question or Q&A, wherever functionality you can do it, gives a bit of engagement. Okay, hopefully the functionality will allow it for you to participate and engage. Yeah. So what are the signs and symptoms for acute otitis media might you see? So in young children, what might you see? Might see them tugging. We mentioned that, didn't we? Tugging. Okay, so let's go to holding, tugging, rubbing the ears, poor feeding, restlessness. What other things might you see if it was externa? So we mentioned already that you get severe earache, especially if you jaw with your jaw, if you're chewing or around the jaw, if you're tugging on the ear, might be hurting you. You might get itchiness. And remember, these are bacterial or fungal infections of the actual ear canal. Other things that you might see is tenderness when you're moving the jaw, swelling in the actual ear canal. And you may also get discharge in the actual ear canal. Going back to otitis media, what's usually the cause? Well, we know now the cause tends to be virus, mostly viral induced, and as a result, antibiotics don't do much, and it's self-limiting. Whereas we know with otitis externa, it tends to be irritants in the ear canal, and it's predisposed because of eczema. Maybe the person's got poorly controlled diabetes. They wear hearing aids. Maybe water's been trapped in the ear. So these things can affect. So that's why otitis media is mainly of the middle ear, and otitis externa affects the ear canal. So this is good idea to differentiate between the two. So again, when we're looking at red flags for acutitis media, and we mentioned this earlier, as long as it's not an urgent where they could be at risk of harm or health, or meningitis or mastoiditis, then apart from that, if it's something that they need to see the GP within 24 hours, same day or the next day, temperature, shivering, hot and cold sweats, swelling, any fluid leaking, hearing loss, vomiting, nausea, sore throat, dizziness, weakened immune system that might predispose them to risk of that infection. See, there's a Q&A on there. Yes, exactly. Pressing the targets will cause pain, especially for those individuals with acute otitis externa. Thank you so much, Sangeeta. So that's one of the ways of addressing the difference between otitis media and otitis externa. Thank you for that. Brilliant. But of course, it's not definitive. We know that it's not like, black and white rule for everyone. Okay. So here we are, this patient, another patient. So imagine it's a different patient now. Okay. Okay. We know that this is acute otitis media because we've seen that. All right. Now imagine this individual. Okay. Fred came to you, brought in by mom. Okay. You see this individual, okay, and they say, oh, Fred's not being well. He's been not eating well, temperature, he's lost his appetite. He's not interested in doing his day-to-day chores. He's not participating in school. He's painfully tugging at his ear. And you look at this child individually. And now, not looking at the left picture, but looking at the right picture, it can be sometimes mastoiditis. And I know you guys know it's mastoiditis because, but look at his left ear versus his right ear, and you can see the protrusion of one of his ears compared to the other. And if you look back at the left picture, you can see the mastoid bone distinctly inflamed, okay, causing that movement of that actual ear outwards, causing that. And we know with mastoiditis, it's an infection that spreads from the middle ear to form an abscess, and it can form in the actual mastoid air spaces of the temporal bone behind the ear. Really serious, because if we don't address it, it can cause permanent disfigurement for that child for the whole of his life or her life. It can also increase the risk of sepsis as well, because it can go to the rest of the body, and that's really where so we need to be aware of sepsis as well for these individuals. So although mastoiditis is relatively rare, because as pharmacists now we're going to be seeing patients more with acute otitis media, and acute otitis media usually is a precursor, if it's not addressed by the body's own immune system or any intervention that we do, can lead to mastoiditis going forward. So it really, I've never seen one. I hope nobody else sees one, but if you do, straight down to A&E. There's no question about it, because there's more at stake than just risk of infections coming out from the ear requiring antibiotics. It needs systemic antibiotics straight away. And because it can spread from deep to superficial, it can increase the risk of bone loss around the ear, causing permanent disfigurement going forward. So yeah, so you got it right, absolutely, mastoiditis. So this individual, okay, so Beryl, she comes in, okay, she complains to you. She knows you can't really see her ear because she's outside the age and remit, but we've got a duty. We've got a duty of candor. We've got a duty of responsibility to our patients. And you know this patient, she comes to you all the time. She's diabetic. She comes in, she goes, pharmacist, please help me. My ear's red, it's sore, it's painful. I've got a bit of a fever and I'm not sure what to do and how to deal with it. And I can't see my GP. What do you think it might be? Yep, we got a question here. Okie dokie. Oh no, we haven't. It's been answered. Okay, that's it. So what do you think it could be? For those individuals who are thinking that, they're not happy, could it be cauliflower ear? Has she had some trauma? Yeah, that could be a good potential reason why she's come in and presented. And you could ask her these questions. Say, Beryl, have you been going to your MMA classes? Have you been doing your taekwondo or going boxing or anything? I mean, like, she's 86, she's not likely to go. But anyway, it could be a potential that she's hurt herself, she's fallen down, causing inflammation. But this particular presentation, which you got here, is more likely to be cellulitis. Okay, and as we know, it's hot, it's painful, it's red. She's getting a fever as well. So you're joining all the dots and you're putting all the puzzles in its place. Cellulitis of the left ear, and she's got a slight abscess there as well. If she had no pain, if she had no soreness, and it presented for weeks and months, it's then more likely to be a cauliflower ear as a result of trauma. But because she's got pain, because she's got it feels hot and there's fever, there's an infective component behind it. And again, red flag. Yes, because pin abscesses or necrosis will damage the ear permanently, can cause the risk of sepsis in terms of if it's not addressed. But this ear, the pinna of this ear, you can't see the helix or the anti-helix. The structural landscapes are all gone from what we saw before, right? So this is important that we get this seen pretty sharpish, because it could further evolve into sepsis for that individual. So I hope this just gives you an idea of the barriers, the competency, the confidence, and what we need to demonstrate, and utilizing acute otitis media as a way of demonstrating clinical knowledge, but expediting it to our patients and ensuring that we're seeing the right patient at the right time and making the appropriate referrals. Because again, the gateway points have been provided for these red flags, the risk of serious illness, and this is where we need to become a bit more articulate in our documentation and the questions that we need to ask and the things that we need to observe going forward. So how do we take pharmacy first forward? And this is where hopefully it will give you more sort of impact of exploring how pharmacy first model that we've seen with acute otitis media, for example, can be foundational for pharmacy-led long-term condition interventions, like in respiratory, like in hypertension, cardiovascular disease, anything. Because if we can get pharmacy first right, we can do everything else, because it's the same sort of clinical pathways in terms of addressing the red flags and going down pathways. So I think from our point of view, we have got our ability here in context of the NHS aim to shifting care closer to home, to community services, and thereby, again, reducing pressure on our GPs, helps really improve the prevention and early stage detection of disease. So if a person, for example, is coming to your pharmacy on a regular basis, they've got COPD, they get all these inhalers like Trimbo and Trelegy, and they get a lot of mucus, so they're using carbocysteine and using the blue inhaler like, Thomas the Tank Engine. The patient who's got COPD, okay? And they come to your pharmacy and says, oh, pharmacist, I need that Benylin again, or I need that Bronchostop. I'm getting breathless, I'm getting wheezy, I'm producing a lot of muck. Why send them to the GP when we are aware of the signs and symptoms of deterioration of their condition? And we can say, you know what? You're on, for example, Foster, you might benefit from having Trimbo or Trelegy as triple therapy to help bring out the mucus and muck. And then we can follow that on. So this is where we can address healthcare priorities for our local commissioners, but also the national commissioners, and utilizing our ability to access patients for our services much more readily than that of GP practices. And your pharmacist, majority of the patients coming to you are your patients. They tend to be your community. Okay. So with our current scope of practice and our current sort of PGDs that we use for pharmacy first model or IP prescribing, I think we can use this as a platform, as a blueprint to emphasize how governance and digital infrastructure can be used and leveraged with these sort of long-term care provisions going forward, be it respiratory or cardiovascular disease. So what I'm trying to get across to you today is, don't just think pharmacy first and that's it. If you want to build an establishment within the community, moving away from price of drugs and getting it from the cheapest wholesaler, either ethical or generic buyers, and doing all that and wasting your time around that. How can we make pharmacy fit for purpose for the future, utilizing pharmacy first as a foundation and building on long-term care management and interventions? And we know there's a massive issue right now. And this is why the 10-year plan, the NHS 10-year plan, is addressing that fact that we're still getting so many patients with poorly managed asthma, diabetes, cardiovascular disease, any respiratory conditions, rocking up to A&E, rocking up to hospital, because currently the GP's infrastructure are not able to manage the whole raft and wave and tsunami of patients with these multi-morbidities, with complications that cannot be addressed there and then, and thereby the patient has to go to A&E. So this is where I think we should be starting to look at and investing in ourselves as pharmacists. And when we do our revalidation, start doing long-term care management, start thinking about how we can improve the access to our patients, for our pharmacies, to our pharmacies, by providing safe spaces for patients with COPD, with asthma. And in fact, my local area in Southwest London, our local GP Federation only recently published on LinkedIn that they've won monies to try to engage patients with asthma and COPD in the community, and engaging community infrastructure by addressing those individuals before they become worse and rocking up to A&E or locking up beds. Because you have seen patients in beds in the corridors and everywhere, and the access to services such as specialisms are becoming much more difficult to get, where patients can potentially be waiting for maybe 1 to 2 years for specialist services because they've been referred on to, and again is causing a massive backlog. So we can actually identify those individuals and act more preventatively to help reduce the backlog going forward. And that's where the money should flow, because the NHS 10-year plan is looking at how they can invest in primary care so that we're keeping patients in primary care, we're addressing the services that they can utilize more so. And that's where the money will flow going forward in the new sort of integrated neighborhood teams going forward. So I'd like to give you an example of where I did a pilot with the Health Innovation Network and the Southeast London ICB and my pharmacy and the Lewisham Care Partnership, um, and King's College Hospital, where we were looking at, we know there's an issue with chronic kidney disease, and CKD has become pretty sexy now because there's a lot of evidence from the sort of cardiorenal metabolic conditions of patients where diabetes and hypertension can impact on patients' kidneys. Now, the kidneys are the canary in the mine. And what I mean to say is that if your kidneys are upset because your kidneys are super sensitive, if we can get your kidneys right, we ultimately benefit your cardiovascular sort of platform. So it means we're also getting your diabetes right. If they're diabetic, we're also getting the hypertension right because they've got blood pressure. We're also addressing their lipidemia because they've got lipids. Because the kidneys are impacted by worsening diabetes, worsening hypertension, or lipid control as well. So we did a project, and I was the one as a pharmacy executor, and it was led by the Health Innovation Network, King's College Hospital, and the Southeast London ICB, with the help of the local GP practices, where I ran a clinic, a CKD clinic within my consultation room, and patients were actively being referred to me by the PCN in the Lewisham Care Partnership pathway for patients with hypertension or blood pressure or both, who had early stage chronic kidney disease. And they did a sort of like mapping of screening of 97, nearly 100 patients. And those individuals who were eligible to be seen by me were booked in with me in the consultation room. And the consultation took about 15 minutes or so, 15 to 20 minutes. where we spoke about lifestyle, diet, and exercise, but also as a pharmacist and as an independent prescriber, I looked at their therapies as well. So I addressed whether they're on maximal sort of ACE inhibitors or ARBs, so candesartan or ACE or ramipril or the such, and whether they're on the appropriate dose or we can go higher. I measured their blood pressure, and we had a point of care testing kit, because point of care testing kit is becoming very important in getting the data because of the lack of flow of information from GP practices to obtain blood test results. And what we did was we checked the blood for the kidney function, eGFR, creatinine, and potassium, and then we were able to escalate their ACE or ARBs. And also we introduced statins if they weren't already on statins, because by improving their lipid profile, we reduce their lime scale in their pipes and reduces, which lime scale can obviously, when I say lime scale, I mean the excess production of cholesterol in the pipes, which when I suggest to patients, it's like lime scale in your plumbing. So when that cholesterol and hypercholesteremia causes that narrowing of the blood going to the kidneys start suffering. Like a heart attack, you're having a kidney attack because you're not getting enough blood to the kidneys. So by keeping your pipes nice and open, by reducing the cholesterol, by having cholesterol tablets, and also by keeping the pressure down, because then it doesn't harm the kidneys, by giving ACE or ARBs, we can improve the kidney profile. We also were able to initiate an SGLT2 because we know with those patients with certain eGFRs and with certain UACRs, we are able to do that, and it helps reduce the burden on the kidney. Ultimately, the reason why we were doing this and the outcome of it was because we know, and this was the sort of like the motivator from the ICB point of view and the NHS England point of view, was that we have got an oversubscription of patients who have got end-stage renal failure and who were going on dialysis machines. And we found that especially in areas of depravity, where English may not be the first language, where access to healthcare may not be there, where there may be less green spaces, more smoking, more risk of diabetes, more chicken shops, and more these, that area where that it's too many people not gaining the access where they need to, they're higher risk of having end-stage renal failure and or higher risk of going on dialysis. And as a result, in those areas, now there's a waiting list of going on dialysis because there's just too many people. And if we get to that stage nationally, we're going to be in dire straits, because that means these people are going to have a very significant decline in their health because they can't get into dialysis. So the dialysis, of course, costs us as taxpayers some tens to 20,000 to 30,000 pounds a year. So by having that intervention, and the money was then science ring fenced for this pilot to demonstrate where pharmacies can provide this service within their practice, having access to their records through EMIS or System 1 on their laptops to be able to distinguish whether or not we can escalate the patient appropriately. And what it showed was that those patients who were seen, this nearly 30 patients who were seen in that short period of time, they get the same day testing, they had counseling, we talked about lipids, we talk about blood pressure, salt, cholesterol, and optimize the therapies, that patients had access to these sort of clinics within pharmacies, and reduce the pressure on the GP practices. But also, by the virtue of us doing that, the GPs got something back. They got QOF points, they got optimization of their diabetes, they got optimization of their blood pressure, and those patients were having also statins as well. So it gave them back something, but also it reduced the therapeutic inertia of having these medications, because they're having that sort of specialisms within the community. But of course, you need to have that specialism in the first place in order to engage, and that requires obviously from your CPD point of view. So I hope it gives you an example of where things are heading, I think, going forward, and where the landscape of pharmacy is moving towards more of a preventative stage rather than a firefighting stage, that we're only giving the blue inhaler because someone's having an exacerbation because they're coming in for a loan or an emergency supply. But how can we intervene with these individuals? So another thing that's happening in Northwest London, there's a consultant pharmacist called Sotoris, and he's working there to help look at cardiovascular prevention in line with NHS long-term plan, where patients where patients are being signposted to pharmacies with high risk of having heart attacks and strokes or poorly managed lipids, and where statins and ezetimibe as well as lifestyle and diet are being escalated going forward. So I guess from our point of view, we have got key enablers because we've got a fantastic workforce within our teams. And we know with pharmacies now that the utilization of pharmacy technicians can be utilized to help with the provision of medicines and checking and giving out the flu jab, but also digital integration with GP systems needs to be done going forward as well. But of course, this can't all happen overnight. It has to be done through pilots. And sometimes, ladies and gents, you've got to give something in order to get something. So if you are looking for these pilots, speak to your local health innovation network, speak to your local GP, speak to the local ICBs and the federations and local LPCs as well, in order to see what the main issues are going forward. Yeah. So from your point of view, engage. If you want to get involved, because ultimately the price of amlodipine and bendrofluozide is not going to meet the needs of your workforce, of your profession, and of your outgoings. And we need to start looking at other interventions that will help our business succeed, but only succeed in helping our patients in keeping them healthy at home and reducing the burden of secondary care, like the example of end-stage renal failure, like the example of dialysis going forwards. So that's my take-home messages for you. And the very final bit, if you allow me just a few more moments of your time, is about how do we pitch with purpose? And this pitch with purpose is because if you're interested, we need to do our homework before we approach these sort of commissioners. We need to do our homework before we approach these people who are going to make that change, who are going to decide whether they've got a pot of money, who gets it? Does it go to the GPs? Does it go to the federations? Does it go to community pharmacies? Does it go to LPC sort of organizations? Who gets the money? And this is where we need to show our benefit. And this is obviously an organizational thing, but if you're part of an LPC, if you're part of a group or a governing body like Avicenna or NPA or any organization which deals with it directly for your members, it's important that we utilize the strengths in order to get the funding in and in ensuring that it's done in a sort of clinical governance way, but also equitable way as well. So this is one of the things that I utilize. So training pathways, think about how we're going to be utilizing our resources, making sure that we know how the impact on secondary care needs to be addressed and how much of a money black hole it is, and how £1 spent upstream, like in community pharmacies, can save £10 or £100 downstream in a period of time. We've got the ability as pharmacists to know our patients. We know what the issues are because we engage with them, we engage with their families, but we also know from a personal level what the issues are going forward, because they always confide in us, and we don't have that sort of stringent timeline that GPs have going forward. Now, this needs to be as an asset when we're talking to our commissioners and decision makers, that the 10-year plan is looking at a shift closer to home. We need to look at how we integrate as part of that sort of neighborhood health model going forward, and how as a pharmacy we are actually the center of the community. Because if you look at any community going forward, for a thriving community, you need, for example, you need a GP service, of course, but you need a pharmacy where people can get minor ailments, keep healthy, self-care, but also able to get their prescriptions as well, and also find out what is happening in the local community going forward, because otherwise it's very much a central point of conjunction for all our patients coming forward. Pharmacy we have such a massive sort of like expertise and uh, prevalence. In fact, some Mori Mori studies advised that pharmacies were one of the top healthcare professionals that people had trust in and engaged with. And we know that 80% of our population are within a 20-minute walking distance of a pharmacy that they can attend. So it's important that we build upon that. We also know that we're doing well with our pharmacy first, especially with signposting, but we need to ensure that our GPs are also embedded in making those active referrals competently and confidently using the IT systems as well going forward. And we also know from the NHS 10-year plan, as we said, it very much fits in with the NHS long-term plan in terms of prevention is better than cure, provision of vaccines, both injectable and nasal spray, provision of COVID vaccinations, RSV, all the services that we provide in addressing the sort of detriments of health and access that patients are currently having. And we need to really build on the success of Pharmacy First in bringing it forward and how we can adapt and adopt it in utilizing the infrastructure of what Pharmacy First teaches us in terms of its PGD, triage, as well as referrals, and leveraging used how we can actually benefit on with long-term conditions, like we mentioned with CKD, respiratory conditions, and lipidemia. And this, we can't do it in silos. We can't do it individually. Sometimes we need to have that sort of uh, membership approach. And this is where I think NPA really can really give you benefits. So, if you're not a member of the NPA, have speak to your local representative, come in and look at the website, because we need that sort of um, uh, uh, expose towards what pharmacy can do and be that triage and leverage at the House of Parliament and House of Commons to make sure that our voice is being heard. And luckily we've got members like Sadiq, who's a pharmacist, a member of the Labour Party in this area, and is lead for his constituents. And he's very much a community pharmacy focused individual. But we've also got other pharmacists as well in that area. In Parliament as well, who are trying to advocate our benefit going forward. But utilize your pharmacy membership with the NPA and with other members to really advocate what we're doing and push the agenda. Don't just rely on Pharmacy First as an individual. You've seen already the issues. We need to go upstream and try to see how we can take pharmacy forward, utilizing and managing long-term conditions and prevention of those long-term conditions going forward. So hopefully it shows you some ways of pitching your sort of benefits, the clinical governance, the structure, the execution of it, utilizing pathways, making sure everyone is aware of what referral mechanisms you've done and having that feedback loop. But whatever you do, when you're talking to people at high level, align it with the NHS priorities. Find out what is their motivator, their instigator, because ultimately, if you are a solution to their problem, you will then be able to gain those contracts, not only as an entity of a single pharmacy unit, but I think as a profession, we can all benefit, because if we all benefit, if one person benefits, we all tend to benefit, because as a result of the downstream perception of pharmacy, what pharmacists can do. But if we are not engaged at all and we're just stuck in our own silos within the four walls of our pharmacy, thinking that we're going to make money out of selling Robitussin over winter or doing the flu jabs or doing, these sort of things, then ultimately this is a very short-termism mindset. I know it's hard, I know it's difficult, but in strength, we have numbers, and we're all trying to achieve the same outcomes when we're proposing changes to our healthcare priorities and outcomes. And remember, we're a cost-effective provision. We are accessible. Our open hours are longer than that of the GP practice. And we are also covering Saturdays and Sundays as well in terms of the approach. Healthcare on the high street. And it is a scalable, sustainable model. So if I can do CKD in Ladywell Pharmacy in Southeast London, with the partnership with the local PCN, the local Lewisham Care Partnership, and the King's College Hospital and the Health Innovation Network, then why can't we scale it out so that we're all able to benefit from those interventions and the care in the community that we get? And money will follow 100%. So hopefully my point of care testing with CKD really showed high outcome for our patients, and the feedback was really beneficial. And it wasn't like as if we're trying to reinvent the wheel. We're trying to show new models of working and new models of care for our patients who otherwise would not have access to our services. Same way with the Northwest London with the CVD and lipid optimization, same way of doing that as well. And I'm thinking, my personal opinion is respiratory would be a really good way of trying to get involved. So speak to your local PCNs and neighborhood teams and ICBs to say that, you're interested in respiratory. I can help optimize asthma or COPD. And my idea really was trying to, with regarding asthma specifically, is getting pheno in pharmacy. If we can do hypertension, case finding of hypertension in pharmacy, and we can use the ABPM machine, pheno in pharmacy is absolutely a no-brainer. It's all a machine that you just got to blow into, and it gives you a color code whether or not the person's likelihood of having asthma, which then would then prompt further escalation. And pheno is one of those criteria which the new asthma BTS sign, NICE BTS sign guidelines, which came out in November 24, advocates as first line for both children and adults. And the fact that right now there's a massive issue because we've got so many suspected asthma because we know it's asthma, but we can't get pheno because we don't have access to it. So why can't pharmacy get access to pheno in order to get some money back as a result of doing the service, but also meeting the needs of the GPs for their cough so that their asthma patients are now appropriately diagnosed? Pheno in pharmacy is a non-brainer. Anyway, but I digress. So going forward, use data to strengthen your pitch. Okay, look at the local data that there's a need. Okay, find out what needs to be addressed. Look at the patient's number screened, what patients are currently being followed up, where is the gap currently with the current state of play, the current process, and then come out with a pitch which you will be able to achieve within your pharmacy or within your group of pharmacies, that you can say, look, we can provide this at scale at a cost-effective approach, but we would then get paid for that provision and also for the equipment as well going forward. And you incorporate all the diagnostics and the consumables along with it as well. And you will find that patients are seen earlier, patients are managed appropriately, and there will be more trust in the system with the pharmacy based on pharmacy first going forward. And I think the return on investment really is the biggest crux, because there's no point investing time in a particular service when you could be, I don't know, doing a private prescription of Manjaro or whatever, so we need to make sure it's equitable, it's feasible, but it's also, there's a longevity to it, towards it. And I think with Manjaro and stuff, although it might be a quick win for pharmacies going forward, it might not be a longevity process because of A, the price, B, the access, and C, the NHS England rollout that's happening in GP land at the moment. So we got to think two steps ahead, I think, going forward. So your framework for your building approach needs local assessment, like you did when you did your pharmaceutical needs assessment. When you're opening your pharmacy, it needs to find out what the need of the community is within that area, but from a service level provision. Pilot design and looking at the scope of what you can do within your capacity, within the capability of your practices, and also engage with your stakeholders, especially those individuals who are going to be parting with money your way. Look at any data that might come out with it. And Community Pharmacy England has got some awesome data behind the needs assessment, behind the different areas in terms of long-term conditions, but also look at the local P&A data as well, and look at the funding model. How is it currently funded? What inefficiencies are there? How is it being wasted, more likely, with the current setup? And what you can do differently within your pharmacy and pharmacy teams and pharmacy groups, if you've got a group, to manage these models effectively, so that you can show a return on investment for the NHS, but also more direction towards the provision within your community pharmacy. And again, we're going to evaluate this, going to scale it up. And hopefully, if you can do it in your area, in your patch, in your PCN, or within the group of pharmacies that you belong to, you can scale it up and say, look, the NHS, this is a proposition that you can utilize and copy and paste in other parts of the UK going forward. And that's the way it should be, because otherwise, if you're not in it, you can't win it. Okay. And I'm not saying you're going to make money from day one. It's an investment that you need to do, and sometimes, yes, if you don't try, you won't learn, And if you fail, that's also a learning curve in terms of what to do best next time. Because, like I said, you got to be in it to win it. So common objections and responses, the commissioners or the people who are decision makers or the GPs or the PCN clinical leads might say, we don't trust pharmacy. Well, show them your training, show them the governance, show them the infrastructure that you've done, able to prove from Pharmacy First, but also your other PGDs, both private and NHS. They might say, oh, well, GPs lose control. We don't want GPs to lose control. They are the essence of primary care. Well, hold on. GPs are just one part of that pathway. Pharmacy and other providers like dentists, like physiotherapists, like social health care workers, like mental health care workers, like district nurses are all part of the same team. And we cannot address the needs, the agenda of the NHS 10-year plan without addressing the collaborative approach that we need to do in order to achieve it. Okay, because currently NHS think you think that the NHS is reliant on just the GPs. They're buckling, they're struggling in order to give the patients who are at the highest risk the appointments that they need. You might say, no, you know what, my workforce is overstretched. I can't do it. I'm the pharmacist and I'm the only one who knows everything. You're wrong. Your technicians, your pharmacy technicians, okay, your dispensers, your counter staff, everyone has a part to play. And like in Pharmacy First, where the patient might be looking at strepsils or looking at something for the ears or nose spray, Beckonase over the counter. That's an intervention that your healthcare or counter assistant would make to say, you know what, the pharmacist, if appropriate, and of course, as long as they meet the criteria, you would benefit in seeing that pharmacist as part of that referral. So utilize your resources and your workforce in order to gain the maximum benefit. But also, you can use the same resources when we're doing these sort of long-term care condition management going forward. Blood pressure checks. I mean, like blood pressure checks, any qualified person can do that. ABPM application, any person can do that. When it comes to the interpretation and actioning, that might require maybe someone who's got more knowledge behind the therapeutics, like a pharmacist in that area. And finally, you might get an objection to say, oh, you know what, our IT systems don't talk to each other, so we don't know what you're doing in pharmacy, and the GP practice are reluctant to send you anyone because they don't get any information back. Well, we have got interoperable areas. We've got areas where the farm outcomes or Sonar or any of those systems can speak to the GP practices. As long as the GP Connect is switched on, they're able to receive that information. But there's more than one way to skin a cat. Email, sending out reports, get them to scan it in, get them to file it on the patient records. So then at least the GP has that confidence that whatever referrals that they make, either through Pharmacy First or through long-term conditions, because now you're providing asthma objective testing, like through Pheno, then they're going to get the report back that they can action and put towards a system that will qualify for their QOF points. Ultimately, mandatory and money. There's two things that I was told by a very senior pharmacist that motivate people in healthcare. It's either mandatory that they've got to do it, or there's monetary sort of outcomes. Don't forget M&Ms. So the enablers for success is, if you're not already, being an independent prescriber will help that sort of provision, especially when you're prescribing outside of a PGD. Say you're doing it for a CKD clinic like I was, or you might do it for respiratory or COPD clinic or asthma, where you're escalating someone based on the current guidelines. Have that training. If you haven't already, please do look for it or work within a PGD that you have, and utilize the pharmacy technician roles, because they're absolutely amazing and vital to the secret success of keeping our patients healthier at home. It's not a one-man band anymore, I'm afraid. Clinical governance frameworks make sure everything's embedded to allow that sort of functionality and to ensure that patients are getting the best outcomes, but in a safe format, and making sure that we are integrating with our information between what we do and what other people who are care of that patients, i.e. the GPs, will also need to know, because our interventions will be also their concern. So it's important that what we do, the feedback loop is in there. And this will help not only build a more serviceable model for the NHS going forward, but it also will provide a more sustainable model for a functionality of that's already there, and utilizing our pharmacy premises much more equitably than we have done when we're just reliant on the price of amlodipine and benzoyl. So we need to unlock the funding, and we need to demonstrate this, and engaging with ICBs as part of that sort of primary care transformation budget we need to address the right people, because how else we're going to be unlocking the money? Okay, we need to also speak to people at NHS England at the pharmacy integration programs, finding out if these are pilots that they are looking at from a sustainability point of view, and bidding for those pilots going forward. And look at your ICBs, but also your, sorry, PCN, DES, but also local authorities, and those individuals who may not need to be addressed, like in federations, because ultimately they will get the best bang. Look at any hub and spoke models at scale that, can we utilize our services that we've got in order to make it more equitable and more scalable going forward. And the last couple of slides that I've got here, my call to action for you is identify local priorities. Find out what's the biggest thing in your area, because you're going to be able to mobilize on that area by the ideas of long-term conditions based on the foundation of Pharmacy First. Build proposals, utilize the data that you've got, find out and extrapolate what is the biggest burden of health inequalities and economies within your area, and engage with your PCNs, engage with your clinical directors, engage with the ICBs who can potentially help and guide you towards that. And then with your patients, once it's all established, because you want to identify patients who would benefit, and then you can have that sort of collaborative approach with your GPs and your pharmacies, that they can signpost patients to you appropriately, so you can engage with things like pheno testing and so on and so forth, and measure impact. Remember, it's not a one-trick pony. You want to get data from how many patients you intervened with. You want to be able to identify the outcomes, not just output, but the outcomes, and how we've able to be able to improve patients' lives. And engage with publishing. So I was asked to do a published poster for the CKD work, which got approved, and both myself and the pharmacist who owns the group of pharmacies that I work for as superintendent, Sanjay, we're up for an award at the ICB Awards, hopefully next week. So we're shortlisted for this CKD work that we did. So I'm hoping that it will be a really good proof of concept, that if we can do it for CKD, as something as complicated as CKD, surely we can do it for asthma or COPD or something else. Yeah. So here's some references that if you haven't had a look at, please do have a look at, and it'll give you some more insights about what other information is out there. But moreover, scan for feedback, scan for your certificate. If you've got your mobile phone, just scan it, and then you'll be able to get certification for it. But if you don't mind, send us your email address, and I'm happy to send you the certification for it as well. But feedback is a gift. And I hope that was all right, Helen. 3 minutes to spare. Have there been any
Absolutely
questions?
fantastic. Thank you, Deshaun. Amazing.
Thank you so much. And thank you so much for allowing me to talk to the wonderful colleagues who are registered. If you're not an NPA member already, please do look for it, because it will give you a lot of saving grace in terms of the advocacy that you get, but also engage with these people. Don't be scared. You're not just a pharmacist, just a pharmacy technician. You are a healthcare provider and keeping your communities healthy and keeping them at home. Okay. And we need advocates like yourselves to make that and push it forward. So yeah, absolutely wonderful. And thank you so much. I'm happy. And of course, if you don't know me already, then you're more than welcome to text me or email me. If there's any questions, I'm happy to assist in any way. I'll leave that on for the time being, if that's okay, Helen, just to see if the colleagues have got any questions as well. I can keep an eye on the questions.
Yes, that's fine. Thank you.
Pleasure. Pleasure. Have there been any questions coming through? Oh, there's some questions, I guess. Let's have a look. Can't see any questions.
Asking for your email address. I will be sending through
Yes, please.
contact details for Deshaun. So don't worry,
Please.
you'll receive this recording, the QR code, so that you can do it at your leisure, and
Correct.
also all of Deshaun's details, so you can keep in contact with him.
Please. Yeah. And it's important to keep talking, because what I've learned, I can share. And we're not, living in silos or on islands. We're all together. So let's keep talking and show best practices, because we've got to take pharmacy first, but we've got to take it pharmacy forward now, as my good friend David would say.
I think that's it. Thank you very
Fantastic.
much, Deshaun.
Have a lovely rest of your Sunday. Enjoy, relax, and be good. Thank you so much.
Thank you. Bye.
Bye.